So I'm going to talk to you guys today about ARDS. I now have made this sort of a yearly thing. So some of you have seen a good part of this talk before, but since I did put a new year on there, I will try to give you a little bit of some stuff that I haven't talked about before, some of it because it's new, some of it just because I decided not to talk about it before, but I decided I'd talk about it today. So hopefully there's something in here for everyone. So just as terms of disclosures, I do work outside of Ford. I work for the Michigan Hospital Association and their Hospital Engagement Network. I'm a consultant for them. And then I am on the board of the ABIM Critical Care Medicine. So those of you who are taking boards need to know that nothing I'm saying has anything to do with board exams. I can't give you any questions. I don't know any questions. So don't think that because I talked about something today, it's going to be on the boards. It may be, but it won't be because I'm talking about it. So what I'm going to do today is just talk a little bit, just to start, sort of go over the definition of ARDS and talk about the newer definition, the Berlin definition, which hopefully isn't new to any of you, but I think there's some points that, as we're doing our NIH Rose study, which I'll talk a little bit about, has come up as key points in the definition that we sometimes don't think about or overlook. And then talk about physiology, sort of to really give you a sense of why we do some of the therapeutic things we do, and talk most specifically about vent strategies, since that's obviously the biggest part of what we're doing with patients with ARDS, and then some adjunctive therapies as well. So ARDS was initially described in 1967 by Dr. Petty and his colleagues in Colorado, and described it as severe dyspnea, tachypnea, cyanosis that is refractory to oxygen therapy, loss of lung compliance, and diffuse alveolar infiltration seen on chest x-ray. And honestly, that's, in a nutshell, still the definition. It's become a lot more rigorous, but it is basically what we're looking for, right? And that was sort of first put into place by by the critical care societies, where they came together and said ARDS was defined by a number of things. It had acute onset, a compatible clinical history, bilateral pulmonary infiltrates, a wedge pressure less than 18, or absence of evidence of left atrial hypertension, and that an impaired PF ratio less than 300 for acute lung injury and less than 200 for ARDS. And I just want to go through these and just sort of talk about why they were changed or why they were thought not to be a great definition. So the first part was very simple. Acute onset is vague. What does acute onset mean? Is acute onset a day? Is it a week? Is it a month? So because of that, they wanted to be a little bit more definitive, and you'll see that in the Berlin definition. The second part was sort of bilateral pulmonary infiltrates, which is vague. In the sense of how vague this was brought up by Gordon Rubenfeld when he did a study as part of the initial ARDS network, where he just put up a bunch of x-rays and asked ARDS investigators, is this chest x-ray consistent with ARDS? And I trust that none of you would have a hard time accepting that that x-ray is consistent with ARDS. In fact, I think 95% of the investigators said, yep, that's consistent. But they looked at this x-ray, which I know it doesn't project well, but every time I look at it, it looks normal to me, no matter how many times I've looked at it. And 50% of the researchers said that that x-ray is consistent with ARDS, which I'm not sure we can fix with the definition, but at least points out that maybe we need to be a little bit clearer about what we mean by bilateral pulmonary infiltrates. And then the third part was that the definition explicitly said that the wedge pressure needed to be less than or equal to 18. Obviously, their point was they don't want patients with cardiogenic pulmonary edema listed as ARDS, but when you actually check people's pulmonary wedge pressure, you find that that's a really lousy definition. So this was part of the NIH study that was looking at the question of how to manage fluids. So in that study, as we'll talk about a little bit later, there was a 2x2 sort of stratification, whether the patient was dry or wet, so whether they were diuresed a fair bit or not. And then the second part was whether that management was guided by a CVP or a PA catheter. So a whole bunch of patients who met definition for ARDS clinically got a PA catheter, and you can see 30% of them had a wedge pressure greater than 18, despite the fact that 97% of those had a normal cardiac index. So these are patients with normal cardiac function who are presenting with clinical signs that all of us would say are consistent with ARDS who have wedge pressures greater than 18. So obviously wedge pressure is not a great diagnostic criteria for why patients have ARDS. And then finally, this impaired PF ratio, which obviously still exists in the definition. The problem with it, which is sort of circular, but it existed, is okay, if everybody with a PF ratio less than 300 has acute lung injury, does everybody with a PF ratio less than 200 have acute lung injury and ARDS? Or do they just have ARDS? It seems sort of semantics, but it is true that the definition does not say that PF ratio less than 200 is not acute lung injury, it just says that it is ARDS. And so because of all that, they thought we should probably be a little bit clearer, and as you, I think, know, we got rid of this whole idea of acute lung injury and just called everything ARDS, which you'll see. And then the other part of this was that PF ratio was really not explicit as to whether or not it was on PEEP. So a PF ratio of 300 on a nasal cannula is different than a PF ratio of 300 on a PEEP of 20. And obviously PEEP does affect your PF ratio, as this study shows you, and so they wanted to be a little more explicit about how much PEEP you needed to be on to get the PF ratio to be significant. And so for all of those reasons, this really was thought not to be a great definition, and so we came up with the Berlin definition, which has 3 parts, and the first is timing. And so again, acute onset is now not as vague, within a week of a known clinical insult or new worsening respiratory symptoms. So we have a week. So if something's been going on, if you had pneumonia for a month and you're getting worse, it's probably not this. If there's no insult, then this doesn't work, but within a week is the right thing to say that this is ARDS. The chest imaging, again, the part of bilateral opacities I don't think we can fix if we can't agree what that is, but I think this idea of not fully explained by effusions, lobar lung collapse, or nodules at least gives you some idea of what are the things that don't count. So if you're looking at an x-ray and you're saying, well, I see lobar collapse on one side and I see this big opacity on the right, well, that's not bilateral opacities. Bilateral opacities cannot include effusions or lobar collapse. They have to be something else. Obviously alveolar infiltration is what we're looking for. And then the edema, the respiratory failure, should not be fully explained by cardiac failure or fluid overload. And although that seems straightforward, it's amazing as we're trying to get patients for pedal, how many of you will say to me, well, yeah, but I gave him 6 liters and this x-ray didn't look that bad before 6 liters, so I'm not sure how much of it's fluid and how much of it's non-cardiogenic. And so the question is, do you think their opacities are fully explained by cardiac failure or fluid overload? So if you think they're fully explained, then yes, that's not ARDS, that's cardiogenic pulmonary edema. But if they have a pneumonia and then on top of their bilateral pneumonia, part of it at least is fluid, that's fine, that's still ARDS. It's when it's fully explained by fluid is when it's not ARDS. And again, we rarely use an echo or anything else to make that decision, but if you're really in the, I don't know if this is cardiogenic or non-cardiogenic, then obviously you need to figure that out before you can call something ARDS. And then finally they have this mild, moderate, and severe, and they're very explicit about what's the lower PF and what's the higher PF. So PFs of 200 to 300 are mild, 100 to 200 are moderate, and less than 100 are severe. So it's just very explicit, mild, moderate, severe ARDS, ALI, and they explicitly say you have to be on a PEEP of 5. So if you're on 100% oxygen by face mask, you can't really get to an ARDS diagnosis because you need to have a PEEP of 5. You can have non-invasive ventilation, you can get PEEP that way, but you can't get it without some evidence of PEEP. You can't get the diagnosis of ARDS. And so this is sort of the difference between the Berlin definition and the old AECC definition, and you can just see that basically what it's showing here, not surprisingly, that ALI and ARDS was a severity indicator. Patients with ARDS did worse than ALI, but when you look at mild, moderate, severe, you see further delineation of either when you're looking at vent-free days or mortality, that having severe ARDS is actually worse than having moderate ARDS. And in those two groups used to be combined with the old definition. So we just have a little bit more clarity around what is the severity of someone's disease by using PF ratio. PF ratio does what we expect it to do. It points out people who are sicker. And so now I want to talk a little bit more about sort of ARDS physiology and how it fits into what we do in therapy. And this is sort of the classic schematic that we always see for ARDS, sort of just discussing all of the inflammatory things that are going on in the alveolar space that's causing the difficulty with ventilation. So there's obviously all of this inflammatory milieu here with cytokines, denuded epithelium that allows for infiltration of white blood cells, alveolar macrophages, and then thickening of the alveolar capillary membrane with fluids and proteases, and then finally fibrin and leaking of vessels. And all of that leads to difficulty in trying to oxygenate patients because you don't have a nice clean alveolus and alveolar capillary membrane as you would in a normal patient. The other part of physiology that is kind of interesting is that we've always thought of ARDS as one disease. In recent work done by ARDS-net investigators actually took sort of this interesting idea, which is to say what we can do and what you can do in any population. Typically this is done in nature, it's not typically done in medicine, where you're just going to ask the question, okay, I have a group of people, or a group typically of this is often done with animals, and I'm trying to say, is this one species or is this one class or two? Are there different classes? They just took patients with ARDS and measured all of this stuff down here and just sort of asked the question, in general, do people sort of look like they're all the same and they have the same levels of all of these cytokines and different markers? Or is there one group that has more of one thing and one group that has more of another? Or are there 3 groups? Are there 4 groups? This research could have found any number of subclasses of patients with ARDS, and what they found is that there's basically 2 phenotypes. There's a phenotype that's certainly more consistent with inflammation, and a phenotype that's less consistent. And you can see this, that phenotype 2 here has all of this interleukin 6, interleukin 8, that's more like a septic group. It also has higher vasopressor use, and then there's phenotype 1 that's here. We used to think about, people used to say, well, maybe ARDS you can think about as pulmonary or extrapulmonary, so patients with pneumonia and aspiration are different than patients who get ARDS, let's say, from pancreatitis, and that's true, but this is probably a better, at least phenotypically, a better definition and delineation, and I'll show you later how this potentially might affect what we do for them clinically, but ultimately that there are sort of 2 different phenotypes, and maybe when we're talking about how to treat these patients, we should know what kind of phenotype they are. These are not tests that we get clinically. They're not things we can do yet clinically, but they might in the future be a way of trying to decide how to look at our patients with ARDS. And so when we're thinking about how to treat these patients, it makes sense that we sort of keep track of how severe they are, and based on how severe they are, sort of define what we're going to do. And so the first thing that you can see that is true for everybody is low tidal volume ventilation. And why is low tidal volume ventilation important, or why do we worry about tidal volume? Well, obviously, again, if you think about the difference between what's going on, we have patients with ARDS. The ARDS does not involve every alveolus. It involves some and leaves others that are more normal. And so you have an alveolus in this sort of schematic view that's filled with inflammatory infiltrate, is much stiffer, is much harder to get air into, and then you have an alveolus right next to it that's more normal. Trying to get air into this alveolus, you're going to over-distend this alveolus. And so there's this concern about what happens with our respiratory efforts and our ventilator strategies as we're trying to improve oxygenation here, even though you're sort of having shunting past this alveolus that's filled with infiltrate. And one of the things that we've always been able to learn from animals is that one of the ways we can induce ARDS is just to over-distend an alveolus. And so this is a normal set of mouse lungs. This is a set of mouse lungs that was given high pressure for 5 minutes, and this was given high pressure for 20 minutes. And once you cause volume trauma, so cause high volumes to a mouse lung for about 20 minutes, you get this very edematous, injured lung that looks all the world like ARDS. So we know at least in an animal model, an easy way to produce ARDS is to try to over-distend a lung. So you obviously get concerned when you see this, that if you try to ventilate that patient with high volumes, you might get into trouble with causing that kind of injury. And obviously our only study, our biggest study in critical care to show a survival benefit for patients with ARDS, took advantage of that and asked the question, is it possible that high tidal volumes or low tidal volumes versus high tidal volumes, 6 mLs per kilo versus 12 mLs per kilo predicted body weight, might actually impact outcomes? 861 patients throughout the US and Canada. And all of these patients, again, had volume-controlled ventilation. That was the only variable. And as you all know, 6 mLs per kilo was much better, whether you look at days to discharge, breathing unassisted, vent-free days. Interestingly, the incidence of barotrauma was not different. This is not direct barotrauma. It is lung injury, not pneumothorax, but importantly, impact on mortality. So patients who were treated with low tidal volume ventilation obviously did better. You all know that. And the mechanism is not simple barotrauma, although you obviously see less. And at least in this study, interestingly, you didn't see different levels of barotrauma even using lower tidal volumes. And so the next piece of that really is PEEP, and sort of this recommendation of low to moderate PEEP in patients with mild or moderate ARDS, and more higher PEEP in patients with more severe ARDS. And so why higher PEEP? And it again just comes back to this idea that if we're trying to ventilate this lung, this alveolus more effectively, we can get rid of some of the problems with alveolar filling by increasing the tidal volume of that ventilator and of that alveolus, and using it with PEEP allows for better oxygenation, and better oxygenation maybe is associated with better outcomes in ARDS. But probably more importantly, using higher PEEPs prevent some of the trauma that we cause with our ventilator. And I think overall, the message that we've gotten from treatment of ARDS is the main thing we want to try to do is not cause more problems as we allow the patient to heal from whatever it is their initial insult was that caused ARDS. And so on the left here is sort of the volume trauma that we usually think of in ARDS, and this is the idea that when we overdistend a lung, there's injury to the alveolar membrane, and that's what leads ultimately to the injury we saw when we're using 12 mLs per kilo rather than 6. But there's another form of injury that we see in ARDS, which has ultimately been called that electrotrauma. And it's just this idea that lungs, alveoli, as they open and close repeatedly over time, have stress and strain related to that leads to some mechanical signaling that ultimately leads to an influx of inflammatory infiltrates and cytokines, and that leads to some of the injury we're seeing. And so we're trying to avoid this cyclic opening and closing by giving people PEEP so that those lungs stay open, and so that you're moving air in and out of alveoli that are open rather than allowing for cyclic opening and closing. And it ultimately is left with a graph that I can't get through rounds usually a week without drawing, which is this idea of having this relationship of how the lung works in patients with ARDS. So this idea that when you are down here at low PEEPs, the lung is closed. And the example I always use, the one that makes the most sense if you think about it, is a balloon. Brand new balloon, you're trying to open it and you push and push and push and nothing happens. And then finally the balloon just sort of pops open, and as it opens, it's very easy to put air in. And it's very easy to put air in until you get it full, and when it's full, obviously it's very hard to get air in. So then you have to push and push and push to get a little bit of air. So you have this lower inflection point where the lung sort of pops open, and then you have this upper inflection point where the lung is too full, and that's where you're getting your volume trauma. So down here you're getting at electrotrauma, you're getting that inability to open, and that opening and closing that causes injury. And up here you're just over distending the lung and causing volume trauma. And what you want to do is stay in this sort of what has been called now a safety zone. And so the idea has been, if you can keep the PEEP above whatever this lower inflection point is, you'll cause less injury to the lung than if you use some other PEEP that's lower than that. And this has now been studied in sort of 3 studies which were put together in this meta-analysis that was published in JAMA about 6 years ago now. And you can see, although they're not amazingly different curves, there is some evidence of, at least in patients with, so this says with ARDS and this says without ARDS. So again, this is old definition. So with ARDS just means a PF ratio of less than 200. without ARDS means a PF ratio of 200 to 300, what we now call mild ARDS. So it's not important in mild, but in patients with moderate or severe ARDS, there does seem to be a benefit of using high PEEP. And again, time to unassisted breathing is much more impressive in patients with moderate to severe ARDS as opposed to patients with mild ARDS. So these 3 randomized trials really do suggest that high PEEP is the right answer. The problem is that 3 trials, they did PEEP 3 different ways, and sort of brings in the idea that sometimes maybe it's more than just PEEP. And this study that I like to bring up from Amato just really gets us to the other side of this. So when we start going up on PEEP, it's natural that we're going to go up on our plateau pressure. And so as we talk about 6 mLs per kilo, part of that protocol was not just 6 mLs per kilo, but a plateau pressure less than 30. And so as we go up on PEEP, if we're getting to PEEPs of 24, which are in most of the protocols, it's very easy to get to plateau pressures that are greater than 30. And so the question is plateau pressure an absolute problem, or is it more of a relative problem? And at least this work from Amato, which is very complicated because he tried to take different vent settings from patients who were being treated in the ARDS network over time and just tried to look at how did they get to plateau pressures of whatever they were. So you can see here the plateau pressure in all of these graphs, or at least for these 2 graphs, are the same. They go from 20 up to about 35. But in this side, the PEEPs are the same. So the difference here in the plateau is based on differences in compliance. These patients have more compliant lungs, these patients have less compliant lungs, and not surprisingly, these patients do much worse than these. So these patients with a plateau pressure of 20 do actually better than these patients with the same plateau pressure but with lower PEEP, because these patients have a higher driving pressure, and that it's probably driving pressure that's the issue, because here you can see for the same plateau pressure, if you have a low driving pressure, you do much better than if you have a high driving pressure. So it's not an absolute number that you're worried about, or at least an absolute plateau based on this work, which is obviously retrospective and sort of recreated of what's there. It's not the absolute plateau pressure that matters, it's the delta pressure. So if you have somebody on a PEEP of 24, you don't necessarily have to worry about the same plateau pressure as somebody who have a PEEP of 5. Really should be looking at the driving pressure as your sense of how much lung injury you're likely to be causing. I don't have an absolute number for you. I don't have a driving pressure that I say, 10 is certainly safe, 15 is probably safe, but it's hard to give you an absolute number to say if the PEEP's 20, how high can you go on the plateau and feel okay? It's harder to give you an absolute, but it's pretty clear that plateau of 30 in that patient with a PEEP of 20 is very different. And I would worry about a plateau of 25 with a patient of PEEP of 5 probably more than the latter, just based on work like this. And so this is to give you the sense of what we're trying to say. When I say high PEEP, you'd say, okay, what does that mean? Well, it means a different thing based on which study you looked at. So there's 3 studies. There's the alveoli study, which was the ARDS network trial. There's the lung open ventilation study, which is probably what we mainly use, and then there was Express. So those are the 3 trials. You can see this is the table for the first trial, and this is the table for the second trial. And in the second trial, unfortunately, they actually started with one table and went to a second table. The things that I always point out on rounds is whatever table you're looking at, the things you'll see in the ICU, and I can guarantee you there's somebody in the ICU today on 100% in a PEEP of 8. 100% in a PEEP of 8 doesn't exist on any of these tables, right? You can't get to 100% without a PEEP of, at the minimum, that's low PEEP, so 22, maybe 20. But you can't get to 100% in a PEEP of 8. You can't get to 100% in a PEEP of 10. I mean, it doesn't exist. And probably the other thing that's hard in people who are enrolled patients in rows for us, thank you, gets really frustrating on the way down is you can't get off 50% until your PEEP is down to 16. You can't get off 40% until your PEEP, so you're coming up and down in very different ways in terms of your PEEP and your FiO2. This is not the way we normally manage it. We don't know a right way to manage it, so I always try to encourage everybody to use these tables because at least there's something. We do have a table for rows that's sort of a combination of the LODS trial, but it's some number here, but it is very much higher PEEPs. The Express highest possible actually used another mechanism, and so again, when you say, well, what mechanism should I use? Well, what they used was trying to say, well, how can you figure out if you're not here and you've moved up? And this really is the challenge, because again, the theory is you're supposed to be above the lower inflection point, but I haven't talked to you all about measuring a lower inflection point. There have been studies that have looked at the question of measuring the lower inflection point. It's really hard to do because you have to take patients, let them exhale, fill them up with a liter of air, and then figure and draw this curve of this pressure-volume relationship and figure out where the inflection point is. And once you've done that, that's good for as long as it's valid. So it might be valid for a day, it might be valid for half a day, and you don't want to spend every half day, and you need to paralyze people to do it, which is another problem. So we don't typically measure that, so we try to guess at it. And one of the ways to guess at it is to do this stress index. And this stress index, something I like to do on rounds, but you have to think about it, because I think when you see the stress index, at least me, I'm used to thinking about pressure volume curves. Stress index is not a pressure volume curve, it's a pressure time curve, and so it works very differently. And so the idea is, again, you're providing constant flow, so the first thing you have to do in the ventilator is turn off autoflow if you want to do this, because it has to be constant flow. And under constant flow, how is the lung behaving? And so again, if you think about it, if the lung is too closed, as you try to give constant flow, you're going to have an increase in pressure before things open up. So you'll have a high area, and then it'll open, which becomes low. So that's underfilled, which is different than it would look if this were a pressure volume curve. This is a pressure flow curve. So again, underfilled, it's going to go up high, and then it's going to go more to a natural level. Appropriately, it's just going to be a straight line. Pressure time relationship shouldn't change over time. As you're giving the first bit of air all the way to the last bit of tidal volume, you're in the same sort of ideal spot in the lung. The pressure should go up equally as you go in, whereas if you're overfilled, it'll go in and then it'll hit a point where the lung is too filled, and then you get this push up. And so how do you use that to decide on PEEP? Well, obviously here your PEEP is too low because you're having to open up, do both. You're having to open this up. So as you're having to open this up, the PEEP goes up and then it opens and then it's there. So here you need more PEEP. Here the lung is so overexpanded that you can't get the tidal volume in. So here the PEEP is too high. Here's sort of Goldilocks. That's perfect. So you're trying to find a stress index that looks like that. This is what you see in the real world, and this is unfortunately what makes this really hard. So I have two of these so that you can see here's our constant flow. So we changed to constant flow, and we looked, and so this one looks straight and this one looks like the PEEP's too high. So how do you use that to make a decision at the bedside? You do your best. That's what they did in Express, and they came up with numbers, but obviously asks the question, what's the best way to set PEEP? And that's what we've been trying to figure out. And you can see that in all of these trials, so this is open ventilation, this is Express, which is sort of like stress index. This is another method where they took the same patients and did esophageal monitoring to try to figure out what the right PEEP is. And you can see that in this trial, using different mechanisms, they came up with very different PEEPs. So you can see the PEEPs were much higher here than they were here. They were all using different things, but there was not a great correlation. Probably the best correlation between mild, moderate, and severe. So you'd think if you were using these mechanisms, the patients with severe ARDS should end up with higher PEEPs than the patients with mild ARDS. That was true for the table. Bottom line of all this, I'm going to tell you, the table is probably better than anything else we can come up with. The table does what we expect. Express, stress index, esophageal pressure does not do what we'd expect. Does not go up on the PEEP as patients are more severe. Obviously this does because it's all based on PF ratio, so it makes sense that it would work. And this is the same idea where they picked the same, this is the same researchers, and what they're doing here is they started everybody, they did CT scans on patients when their lungs were deflated, and then CT scans when their lungs were inflated, and they sort of asked the question, how much recruitable lung do they have? With the obvious idea that if you have more recruitable lung, you'd like to be on a higher PEEP. And so they put patients or lungs in quartiles of lung recruitability. So the least recruitable here, the most recruitable here, and that's true for all 4 of these. What's different is, again, the mechanism they used to try to decide on what the ideal PEEP was for each of these patients. So they either used, again, a table, or they used the express trial, or they used stress index, or they used esophageal pressures. And what they saw is, again, the only mechanism that got you a PEEP that was in the right range in terms of recruitable lung was a simple table. That any of these other things, which are more fun to do at the bedside, really didn't get you the answer that you wanted. And so the best default, if you can do stress indexes, you can look at other things, you can put in esophageal monitors, but at the end of the day, the thing that seems to work the best, if your goal is you want to use more PEEP for patients who have more recruitable lung, is simply to use a table that has a PF ratio on it. And this is the other point, that just to make that maybe part of the reason we can't get a great signal is that our patients really are a little bit more different. They're not all the same. And this is just showing you that when you take patients who are in our NIH studies and look at these 2 different phenotypes that I talked about before, that patients who are in phenotype 1, who are less inflammatory or on less pressures, they clearly do better with higher PEEP, more of probably a pulmonary specific ARDS. When they have more of a inflammatory ARDS, the PEEP doesn't seem to make as much of a difference in terms of using high PEEP versus low PEEP, as again in a table, sort of a high PEEP, low PEEP. This is from the ARMA trial, where they randomized patients to high PEEP versus low PEEP using those 2 tables I showed you earlier. And so ultimately this leads to another mode of ventilation, which is simply, if you take the idea that high PEEP is good, so if a little PEEP is good, why not just use PEEP all the time? And that's basically what this is showing you, right? So this is a mode where you've kept the patient, we're calling it CPAP now because we allow the patient to breathe spontaneously, but we're keeping people, you'll see the graph in a little bit, on a PEEP of 30, and we just keep them there. And we'll never let them go any lower. So again, if we're trying to deliver PEEP, and we want to deliver a PEEP of 20, 24, but at some point you're limited, again, by a plateau pressure. Well, you don't become limited at plateau pressure if you never let the patient go any higher than that. So you leave them at a PEEP of 20 and you let them breathe spontaneously. And that would work great in terms of you're not causing any atelectic trauma because you're never letting the patient exhale. You're not causing any barotrauma because you're not pushing any other air. You're just leaving them at one number. And that would be great if we didn't need to clear CO2. Unfortunately, we need to ventilate a little better than what we allow, so we have this magic thing called a release, and that is APRV, which is what, if a little PEEP is good, then APRV must be better. And so we just keep people at this level, and then we do this magical thing called a release. And by doing the release, we're allowing ourselves to get that level of PEEP for the entirety of the respiratory cycle. And that, I think, makes a lot logical sense to people, and obviously a lot of you have used it in the ICU. My concern with it is I'm not convinced any of us know what we're doing, and that's, I think, for 2 reasons. This is the first. So when Dr. Habashi talked about APRV, he had this very specific thing he wanted you to do, which is, he said, okay, when you do a release, the patient has a peak expiratory flow, and then their expiratory flow decreases at some rate. So that's a rate, that they're all different rates. But he has this magical line, and how he gets this magical line, I don't know. But he has this magical line called de-recruitment. And he believes that if you catch this expiratory flow before it is 50% of the peak flow, and you stop the release at that moment, the patient won't de-recruit. They will exhale, but they won't de-recruit. It's a magical idea. And so, but you can't do that if you don't know this flow rate. So if you just say, like I do, everybody on APRV just needs to have a T-low of 0.4, well, how do you know it's 0.4? I don't know how but how you're supposed to know it's 0.4 is you're supposed to graph this out and say, how long does it take to get that expiratory flow to be only 50% of the peak flow? At that moment, that's how long it is. So for this patient, it's this long. For this patient, it's shorter because they have a quicker flow. For this patient, it's shorter. There's also this idea, which I'll get to sort of. His idea is that if you use anything other than a PEEP of 0, and I'll show you why I don't use a PEEP of 0 in this, or a P low of 0, is that your potential energy between your CPAP of, obviously your P high is 30. If your P low is 0, then that's a difference of 30. The flow is going to be much faster. If you use a P low of 15, then the difference is slower. In this, the rate of change here is slower, and you have to allow for a longer T low to get to the same 50%. That's what that little red thing is showing you. So the problem with this is the same problem I have with stress index, which is I do it once. Let's make believe I actually did it once. I don't think any of you have ever done it once. I know I've never done it once. Make believe you do it once. How long is that good for? I mean, once the patient's compliance change, their expiratory flow is going to change, which means you have to check it again. And so we don't typically do that, but that is what we're supposed to be doing if we want to do this right. And the other piece of this that I think requires some magical thinking is, and I left the figures just because I like the way he describes this. He says, ventilation during airway pressure release is augmented by release volumes and is associated with decreasing airway pressure. So he's telling you that volume here is because you're going from 30 to 0, which is true. You do have expiratory flow because you're going from 30 to 0. Whereas on the other side, in what we would consider typical tidal volume ventilation, they are generated by increasing pressure and lung distension. So he's saying over here we're causing lung distension because we're increasing pressure. Over here we're not causing lung distension because we're decreasing pressure. The one thing that he doesn't mention is that you have to again then go from here up to there, which is an increase in pressure. So he can make believe that this is different than that, but it's not. It's just the same thing in reverse. Whether you go from 30 to 0 or 0 to 30, you're causing a delta change in 30. And that delta change is both ways. And so I think we get into the fact that this are very typical tidal volumes when you do a release. And because he calls it a release volume, it suddenly does not mean we can now ignore what I just told you for 20 minutes about the one thing we know that's true about ARDS, which is you shouldn't have a tidal volume greater than 6 mLs per kilo. He's okay with that. He has much better physiology in animals trying to prove that that actually doesn't cause atelecta trauma. But ultimately, until you have a large randomized trial, you have the problem of you're using tidal volumes, which we've proven previously are dangerous. And here's the other part of sort of this magical thinking. He just wrote a great review article if you guys want to read about APRV. It's this intensive care medicine this year. And he talks about, he makes this interesting, he calls fixed APRV and personalized APRV. So he calls this, and this fixed APRV. So this, because this is so this is the idea. These are pressures of about 25. They're in CPAP mode. So they're in CPAP mode, and then they drop to 0. But you can see that the T low here is much longer than what we typically think of as T lows for APRV. And what he's saying is that this is APRV because we call this CPAP. Now, if the patient is paralyzed, I don't know how this is any different than any other conventional ventilation we'd be giving somebody, right? You're going from a PEEP of 5 to a pressure of 30, so that's pressure control ventilation is all it is. And if this generated a tidal volume of 12 mLs per kilo, I'd be yelling at you. Yet, because we call it APRV and because the patient takes a breath up here, we suddenly are okay with it. And the reason he calls this personalized is because, again, he's arguing that this T low should be based on expiratory flow rates, which would be true if that's what we did, but we don't do that. It's just shorter APRV. But again, there's nothing magical about this, and that magical thinking is what concerns me. So when I think about APRV, this is what I do. So I just say, I'm not going to allow a tidal volume greater than, so I like the idea of keeping somebody at a pressure of 30. That makes perfect sense to me. It will open up alveoli, it will allow for better gas exchange. It will allow you to have less atelecta trauma. But I'm not going to let anybody have a tidal volume of more than 6 mLs per kilo. So I'm just going to say that their P low is higher than what he would normally allow. That's going to cause less CO2 clearing, so you still have to worry about CO2 clearance. And I hate using this mode in patients with metabolic acidosis because they get horrifically acidemic. But this makes more sense to me than using a P low of 0. I just have a hard time with that delta. Yes, gentlemen?
How can you get the 6? Because you're still asking them to leave from the high.
Yeah, so usually when you
more volume, right?
so when you're in this mode and you're at the bedside, right, you're watching the tidal volumes, and you'll see the spontaneous tidal volumes, which are typically about 150, and then you'll have the release, and that'll usually give you a bigger number, and you just look to see what that bigger number is. And I mean, again, does it have to be perfectly 6? It doesn't have to be perfectly 6, just like if I did this in pressure control, I wouldn't say it has to be perfectly 6. But I know that I'm using a delta. I mean, going back to what you weren't here, but you've seen those slides before. When I'm talking about a distending pressure, I know that my distending pressure is, in this case, 15. I'm okay with a distending pressure of 15. So I'm okay if it's 7 mLs per kilo. I'm not okay with it being 14 mLs per kilo.
My understanding is during the release of the pressure, like if you put the pressure at 0, it's not actually 0. The patient doesn't drop down to 0 actually, like because he doesn't have the time to
yeah, that is the magic that Dr. Hibashi talks about. Yes.
So are we still like concerned about putting the ventilator on below 0? So it's going to drop down to 0 and going to have high driving pressure and
So some of us are not, because some of us do that. I am. So that's why I don't do that. I don't, again, the one thing I know about ARDS that I can say to you with certainty causes death is high tidal volume. That's the only thing I know for sure causes death for patients with ARDS. Dr. Hibashi has some great animal studies, some great reasons he can try to argue that what he says happens actually happens. That because you've recruited all these alveoli, each one is contributing so little to the tidal volume that no one of them is collapsing, and so you're not getting the atelectotrauma, that the pressure doesn't really go to 0, but we don't know what it really goes to. But whatever it goes to, it's high enough that it really isn't a driving pressure of 30. I get all of that. I have a hard time, and I know most of us don't do this, but most of the studies, so the reason I brought these up, because he will argue that, no, he doesn't argue, he puts it in his paper, studies using these modes clinically are do as well in the small animal and human studies as this does. So how can this work? I mean, how could it be possible that that doesn't cause atelectotrauma? I mean, it just doesn't make sense. But he claims this is different than pressure control because the patient's in CPAP. I don't get that. That bothers me. So yes, I understand why this, in theory, should work. I'm not comfortable doing that, and I don't know why I wouldn't want to do this. You know, I know it doesn't fit with his theory of what happens in the alveolar space when you do APRV, and it causes, in theory, should cause longer T lows because the expiratory flow is slower, but I just can't bring myself to give people 1.5 liter tidal volumes. It just makes me uncomfortable. Even, and again, calling it a release volume doesn't change the fact it's a tidal volume. You can call it whatever you want. It's still a tidal volume.
It's not really different than the pressure control with reverse IV.
It is different because the patient's in CPAP. So, right, that to me is still I still think that's a value of APRV. As you'll hear me talk, I worry about prolonged paralysis. I don't worry about short paralysis early, but I do worry about prolonged paralysis. What I like about this mode is it gives you an advantage to not paralyzing the patient, potentially could be more comfortable, potentially might cause less sedation. I like all of those things about APRV. I have a problem with 10 mLs per kilo tidal volume. All right. So that's PEEP. So the next piece is non-invasive ventilation, which I wanted to talk about only because it's a great opportunity to talk about this trial, which I didn't talk about last year, even though it did happen before my talk, which is really not technically ARDS, because the authors never said the patients had to have ARDS. The authors said the patients had to have hypoxemic respiratory failure, which they defined as a PF ratio of less than 300, but it didn't have to be on PEEP. So it could be somebody on 100% with a with a PO2 of 280 or something. So it's just a PF less than. So technically, these aren't patients with ARDS, and even in reality, they may not be. They may have unilateral pneumonia for that sake. But I think it does bring up the question of if you're going to treat people with mild ARDS with something other than a ventilator, does it make sense to use a non-invasive ventilation? And so these patients had to be non-hypercapnic because obviously the thought was hypercapnic patients should all get non-invasive ventilation, and they were randomized to standard oxygen therapy, high flow oxygen therapy, and then non-invasive ventilation with the idea that pressure support to achieve a tidal volume of 7 to 10 mLs per kilo. And then all they said is they titrated PEEP and FiO2 to make sure the patients weren't hypoxic. They didn't talk about how they decided how much PEEP versus how much FiO2. And what they showed in the overall population, more obviously different in the patients with a PF ratio less than 200, is that the patients on high flow did much better. And you'll notice on all of these curves, I point this out not because it's significant, because it fits my bias, which is non-invasive ventilation is dangerous when you're using it for a non-standard indication. A bunch of patients who got it for a non-standard indication technically did worse than oxygen alone, not statistically, but clearly did much worse than high flow. So again, high flow has some PEEP associated with it. How much, nobody knows. And again, the other thing I've mentioned on the slide, but I'll reiterate because it's the other thing I see us doing in the ICU that I don't understand. They're all on 50 liters per minute. There was no weaning to 40 liters a minute, to 35 liters a minute, God forbid 20 liters per minute, 50, just 50. You can use 40, you can use 50, but don't wean it. Wean the FiO2, don't wean the flow. Whatever the effect it is, it clearly worked much better than standard oxygen. So, and all of it worked better than non-invasive. So I don't think there's a role for non-invasive ventilation in ARDS. What's the theory? Why high flow?
Why would high flow work on non-invasive?
So this is, I'll give you DiGiovanni's bias. DiGiovanni's bias is that non-invasive ventilation prevents us from accurately assess. I think two things. One, I think it prevents us from accurately assessing patients who are developing respiratory failure and need to be intubated. I think we delay appropriate intubations when we put people on non-invasive because we delay, and I've seen us all do that. I think the second is I think it's a lousy way to be ventilated. I mean, it's just uncomfortable. I think it makes people, you can't feed them. I just don't think it's a good way to try to do something for a long period of time. I mean, and this is short. So the other thing, people who like it would argue, well, they were only on for, I think, 8 hours a day for 2 days or something. It wasn't a lot of non-invasive, so it may have been just it wasn't as effective. I think what's good about high flow is you can keep it on all day, you can eat with it, you can do all these things. It just is a much easier way to provide a little bit of PEEP when you're providing patients FiO2. That's my bias. They can't answer. I can't answer why it's worse. Those would be the things I would think of why it's worse. And then just to show you that not only was it those outcomes in terms of mortality, but in terms of vent-free days, ICU mortality, 90-day mortality, there was all improvements. Again, the points are both that high flow was always the best and NPPV was always the worst of these three. The only thing that was significant was that high flow was significantly better than the other two. The other two were the same statistically. And then, so the next thing we do for patients with more severe ARDS is this idea of neuromuscular blockade, and it's really this idea that doing all of these things, we're again trying to prevent ventilator-induced lung injury, and that before paralysis, when patients have spontaneous respiration, it allows for dysynchrony, which can cause increased tidal volume, so barotrauma, and then also some cyclic opening and closing down here, which would cause some atelecta trauma. And so some of this, when the patient's breathing spontaneously, is going to happen. And if you think about it, all of our ventilators allow larger tidal volume. So you can set somebody on 6 mLs per kilo, but if they want 8 mLs per kilo or 10 mLs per kilo, the ventilator will provide that. So there's that opportunity for volume trauma. And then secondarily, they may breathe out when the ventilator wants to breathe in, and all sorts of things that may cause some active exhalation can cause that atelecta trauma. All of that supports the idea that maybe if you paralyze people, you can make all of that go away. And you can, obviously. You can certainly make the things I described go away. Whether or not you can prevent what the ventilator is going to do anyways, that's a secondary problem. And ultimately that led to this idea of using paralysis early. And it's really this, I think what has been sort of to me, a different paradigm of why this might work is really the idea that we're doing this early and we're doing it for a very specific period of time. So it's 48 hours. It's not prolonged. It's not, shouldn't be associated with weakness. It's really, we're trying to prevent early lung injury from the things we do with the ventilator, especially early on when you're fussing with things to try to get people to be synchronous. That causes the kind of improvements that were found by Pathophysiology and his colleagues in France. This led us to ask, as part of the PEDAL network, whether we can do this, whether this is real, and so we're trying to do it in the US. So just to remind you, we're looking for patients who have a PF ratio of less than 50 on a PEEP of 8. So if you have any patients like that in the unit, Jackie Day, our research coordinator, is looking for them actively, but if you have any, please call us. We have 48 hours from when they first have a gas that fits these criteria to enroll them in the study. So the earlier you call, the better off we are at trying to get them enrolled. But we're just trying to ask the question, is that early paralysis really as effective as suggested by Dr. Papazian? Lots of centers around the country like to get us to enroll more patients. And then the next thing is prone positioning, which I used to have a lot of physiology studies around prone, and I stopped putting them in my slide deck because honestly, I don't understand prone positioning. I don't understand why it should work. I understand the theory, but I was just listening to a talk about PICC lines, and the speaker was talking about how we all now recognize that PICC lines are just as likely to have infections as regular central venous catheters. But he had these long papers where when people used to think PICC lines didn't cause infections, all of these elaborate theories on why a PICC line shouldn't cause an infection that's caused by a typical central venous catheter, and in the end, it's stuff we make up to explain a phenomenon we're seeing that we don't understand. That's the way I feel about prone positioning. I get the idea that if you take somebody who is prone and they have all of this dependent atelectasis and you flip them on their stomach, you have now all of this lung that's much more easier to ventilate. But this stuff that is dependent, gravity dependent, when you flip them over is all going to come down here. Why wouldn't the same thing happen in the anterior lung that used to happen in the posterior lung? People start talking about the heart and what the heart does, and I don't understand any of it. It doesn't make any sense to me. I understand that when you flip them over initially, they're going to oxygenate better, and that is clearly true. But when you have somebody on their stomach for 2 days, which is what the studies did, why that's any better than being on your back for 2 days is lost to me. But ProSiva study showed that worked, and so lots of people now argue this is standard of care and we should do it in everybody. So they took 466 patients in France with a PF ratio less than 150, so again, moderate to severe, 80% on pressors. This is the other part I don't like. 85% of their patients were paralyzed. If you try to prone somebody in our unit, they're going to get paralyzed because we don't know how to do it yet. I'd like to learn how to do it without paralyzing people, but how you get somebody on their stomach with all of these lines and tubes and then let them move is beyond me, but people do it. And anyways, I mean, those kinds of outcomes we don't see in ARDS a lot in terms of survival. It's one study, it's not multi-center. I'm sure somebody's going to want to repeat this at some point, but lots of people argue that this is the standard of care for moderate to severe ARDS. It is not at our unit. I don't know that it necessarily needs to be, but it is something our nurses now are very much willing to do and try to do. So if you have patients who meet this criteria, or typically we use it as rescue therapy, but if you needed to do it for rescue therapy, talk to the nurses. They're usually pretty good. We don't like to do patients who are overly obese. They're learning how to do this, but we have done a couple of patients as part of as rescue therapy for hypoxemia that doesn't respond to other things. And then ultimately this is just showing you that over time it seems like we've gotten better at this, and so the initial studies didn't show a benefit, and then over time the cumulative benefit does seem to favor prone. And then finally, I don't talk about high flow oxygen, high frequency oscillation anymore because it doesn't work. So we talk a little bit about, well, I'll talk about it just in terms of theory. Again, this is why theory and practice doesn't always go. High frequency oscillation sounds perfect for, in terms of theory, right? You've taken somebody, you've put them up here, and you left them there, right? That's so the whole idea of APRV. We've put them there and we've left them there, but now we've left them there just oscillating the lungs. The problem with this, I think, is that you have to paralyze people to do this. But the reality is when you do that, they do worse, or at least they do no different than control. So they don't do better. They probably statistically don't do worse, but they clearly don't do better. I don't know why they don't do better. Again, my bias, because I don't like long-term paralysis, is because they're paralyzed for a long time. But it doesn't work, so we don't do it. And so the last thing, obviously, extracorporeal CO2 removal or ECMO are essentially the same, but we only do ECMO. 3 trials, not a lot of evidence for ECMO, which is what makes it hard for us to continue to do it, but we believe this makes sense. So the early studies, this was Morris from Utah, and they used a variety of centers and really could not show any benefit to ECMO. In fact, the patients seemed to do a little worse. This was CO2 removal. This was not technically ECMO. It was just CO2 removal. The thing that's neat about this, still the neatest part of this study to me, is control therapy was therapy that is better than anything we do right now, because every ventilator change was made by a computer. They actually had a computer algorithm that said, what's the PEEP, what's the FiO2, what's the tidal volume, what's the gas, here's the change you should make, gave it to the clinician and said, do you want to make this change? Clinician said yes, they did it. And it really is something that, it's crazy that we don't take care of patients this way. Why people's FiO2 stays the same for 3 days, because nobody bothers to change it. This is much more logical, but anyways, that was at least as good as CO2 removal. And then there wasn't a multi-center ECMO trial, included the University of Michigan, which showed no benefit. And then the last trial, which finally showed something, was the Caesar trial, which is a very complicated algorithm, but the important thing to recognize is the way they did this, which made some sense, was to say, okay, we have a bunch of ECMO centers in Europe. We have patients who come from a lot of other places. We want to be able to enroll patients from a lot of centers, but we can't do ECMO at a lot of centers. So they enrolled patients and then they randomized them, and they couldn't justify, I think appropriately, randomizing patients they weren't going to get ECMO. So they took the patients who were randomized to conventional ventilation and left them wherever they were. Took the patients who were randomized to ECMO and sent them to an ECMO center, which makes sense. The part that is complicated is, of the 90 or so patients, 22 never received ECMO, because 16 because they improved, 3 died, 5 died, and 1 couldn't get heparin. But of the excluding the 5 who died, we have 17 out of 22 who didn't need ECMO. So ECMO, in terms of intent to treat, we're only treating 57 of these 90 patients. We're only treating about 68 or so with actually ECMO. The rest of them are just getting sent to a center that's really good at taking care of patients with ARDS. So when you look at the improvements with ECMO, that statistically different outcome goes away if you exclude the patients who didn't get ECMO. So if you just take them out of the analysis, there's no difference between what happened at the ECMO centers and what happened at the conventional centers. So it's really hard to say that this improvement in outcome is because of ECMO. It may just be because they were sent to a place where they do a lot of ARDS work. But that's what we have, and obviously our ECMO technologies have gotten a lot better. You all have seen now, most of you, a patient on ECMO. We will continue to do ECMO and try to figure out at least how to do it safely, if not get better data on whether or not it actually works. I think you've all seen patients, I certainly have, who we all felt pretty strongly were not going to survive without ECMO, who survived with it. So it's hard to know what to do with that. So 2 other adjunctive therapies. I want to talk about fluid and steroids. So obviously, as I've shown you this physiology study, we have a lot of water in the lung, and so it makes sense to say, well, maybe less water would be better for the lungs, since we have a lot of alveolar and interstitial fluid that we'd like to get rid of. So again, acute lung injury or ARDS has increased permeability and increased hydrostatic pressure. And so the question that the ARDSNet wanted to ask is, would conservative therapy, so limiting fluid, be good for the lung, or would it be better to be liberal, which would then sort of improve our treatment for shock by increasing cardiac output? And ultimately what they showed, although there wasn't a survival difference, there clearly was improvement in getting off the ventilator when you were treated with a more conservative fluid strategy. The problem with it is this, which is this mess of what do you do with anything. And basically, I used to go through all this, and I won't because of the next slide, but the idea of it is, again, patients were randomized either to get a CVP or a wedge pressure, and then based on which one they got and which arm they were in, you know, you would pick so in this case a CVP. Based on the CVP, if you were in the conservative strategy, you would get whatever is on here, and it depended on what, you couldn't be hypotensive, you had to have adequate urine output. And I'm not going to go through all of this again, but this is how I usually go through it. Bottom line is, people say, oh, I can't do all that, that's way too much work. Can you give me something that's a little bit easier? This is something that's a little bit easier. So this is Fact Light. This is what we should be using for our Rose patients, although we don't have a CVP in everybody. But basically, here's a CVP. So if the CVP is greater than 8 and they have low urine output, you give them Lasix and you reassess in an hour, which means you give them Lasix again in an hour if the CVP is still greater than 8. If the urine output's good, you give them Lasix and you wait 4 hours, and then you check CVP again and you give them Lasix again. So that's Lasix every 4 hours. If their CVP is between 4 and 8, you're doing the exact same thing, unless you give a low urine output, and then you're giving fluid. If the CVP is less than 4 and they have low urine output, you're going to give them fluid. Otherwise, you're not going to do anything. This is very aggressive diuresis. And you can do it this way, and they have papers, they have studies, sorry, I'm not sure what I said again, showing that this gets you the kind of fluid balance they got with the more elaborate algorithm I first showed you. Unfortunately, there aren't great guidelines of what do you do when you don't have a CVP. The only guidelines that exist basically say when you looked at that data, patients ended up staying even. They didn't gain the fluid you normally gain in early ARDS, and so the recommendation is at a minimum, don't allow your patients to get fluid overloaded. That doesn't help you a lot when you're already 20 liters positive when you've started, but there's really nothing else that really is there to guide you. This is, again, steroids. Again, I've talked to you a lot about inflammation. So the question has obviously come up, like every question we have when there's some inflammatory component, is could we use steroids? Overall, the meta-analysis does not suggest a benefit, but I want to look at a couple of these studies. The Maduri study, not because it's believable, because these differences in survival are hard to imagine, that there's a 40% difference in survival by giving people steroids. But when they got them, they received them after day 7, and they got 32 days of treatment. And that's really the key part of this, is that it's a very prolonged therapy. When the ARDS network looked at this, most people looked out here and said there's no benefit. There is this early benefit in terms of getting off the ventilator, which is not dissimilar from what we're seeing with more conservative fluid strategy. The argument's been made that this was a shorter steroid trial, which it was, and that the problem was that we stopped steroids too soon. And so the question is, and the other piece of it is, these outcomes in terms of vent-free days and ICU-free days are pretty significant. There's not a difference in mortality, but if you break it down a little bit further and divide people who got their steroids between day 7 and day 14, as opposed to 14 days of later, there's definitely an improvement if they get early steroids. So, as you all know, this is what I do. This is not what many of you do, but I do try to get anybody with ARDS who's still on the ventilator at day 7 and doesn't have a contraindication to get steroids. And as most of you know, if you just put in ARDS methylprednisolone in EPIC, you can get the entire steroid taper. And I know I'm running over, so I'm going to stop there.